Welcome, everyone. Thanks for taking the time out of your assuredly busy afternoons and mornings to join this webinar entitled Novel Approaches to Bringing Viral Hepatitis Care to People with Substance Use Disorder. Next slide. So I'm Nate Furukawa. I'm a senior advisor for hepatitis C elimination in the Division of Viral Hepatitis at CDC. And I'm joined by my colleague, Kristen Roja, who's a public health advisor for HIV at SAMHSA. And together we'll serve as your co-moderators for today's session. This is a part of Hepatitis Awareness Month. And this is an event that occurs every May in the United States. And Hepatitis Awareness Month activities are designed to help improve everyone's understanding of viral hepatitis and to decrease social stigma against people with viral hepatitis. And this week's theme is reaching key populations in high impact settings. So a little bit about the logistics before we get started. So this webinar is being recorded. During the webinar, participants can enter questions into the Q&A box, and the questions may be answered in writing in the Q&A box as things progress or saved for discussion at the end in the Q&A session. We're luckily, thankfully, able to have some opening remarks by leadership from our respective agencies. So next slide. Our first remarks will come from John O'Merman, who's our director of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. Over to you, Jono.
Oh, thank you, Dr. Furukawa. And I wanted to start off by thanking Nate and Kristen Roja, Ijeoma Hiyasota, and Karina Rapacelli for organizing this and for the leadership of SAMHSA and CDC to kind of see this as a great opportunity for collaboration. I had 4 very quick points. The first is really that this is a natural friendship and collaboration across agencies and public health mandates. I think the diseases in my center, which are viral hepatitis, STDs, HIV, and TB, as well as the kind of the public health and clinical mandate for SAMHSA, they're ensconced in a social, legal, and economic environment that makes us unable to separate both our public health prevention and treatment efforts and our clinical efforts from the context in which people are living their lives, and that can be both legal implications or stigma associated with it, but because we live that on a day-to-day basis, it makes sense for us to kind of reach across the agency boundaries and work together. The other is that that for people who do use substances or misuse substances, it really doesn't matter whether they're at risk for overdose or want to have access to naloxone, or at risk for hepatitis C and want to have access to hepatitis C treatment. These are all kind of health-related opportunities or risks, and it's because we work with the same populations, we should be able to take advantage of the opportunities provided to us by certain venues. So if you are a substance use treatment program, it makes a lot of sense to also do screening and testing for infections that are associated with injection drug use or drug use, and also ideally, if possible, provide treatment or vaccination. And I think for everyone who's kind of joining and speaking in this webinar, we know that our nation has been seeing a major rise in drug use related hospitalizations, overdose deaths of over 100,000 last year, and also increases in transmission of hepatitis C and hepatitis B associated with injection drug use. We've had increased injection drug use associated HIV infections and other kind of bacterial and fungal infections like subacute bacterial endocarditis that are associated with using drugs. So that is not inevitable. All of those are theoretically preventable, including hepatitis C increases, which are 10 times more likely to be transmitted during sharing of meals than something like HIV. So part of this whole webinar is ensconced in this effort that we have kind of as twin agencies to try to do a better job in both preventing overdoses and overdose deaths, helping people who do use drugs, and also preventing our infections and treating people who have them. I also wanted to just highlight that sometimes these are individual-based activities, and you're going to hear today. I got some advanced look at the slides. Some great programs that are making a big difference in this area and showing us the possibilities of what we can do if we spend time concentrating on these endemics and doing providing services for people who use drugs. At the same time, thinking about what policies or practices that need to be changed, particularly policies at a large scale and at your local community scale, can also help us have kind of an enduring effect that can be greater than some of these demonstration projects, but the demonstration projects tell us what we need to do for our policy change. That's what I wanted to say. And I also wanted to thank Jim for having this collaboration across our agencies and encourage everyone to think big and act quickly, because people who do have substance use issues need our help.
Thank you, Jana. Let's advance to the next slide.
Thank you very much for your opening remarks. And now I'd like to introduce Dr. Jim Gandotra, who is the Chief Medical Officer for SAMHSA.
Good afternoon. Thank you, Dr. Merman, for your kind words. And I'd also like to thank the logistic support of the HHS and the contractor for bringing this together. On behalf of SAMHSA's Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman, I'd like to thank all of you for also attending this webinar. As Dr. Merman mentioned, there's significant models that are going to be demonstrated today or highlighted today. But I wanted to also pivot for a moment that this is an auspicious day and month. In addition to hepatitis awareness, May is also Mental Health Awareness Month. And HHS does seek to increase awareness about the vital role of mental health as it plays into our overall health and well-being. And we know that disorders often co-occur. Depression, anxiety, substance use disorder, viral hepatitis, HIV, they all can co-occur in individuals who are dealing with one or the other issues. Many individuals with viral hepatitis or HIV have an increased incidence of depression, as well as substance use disorder. I'd also like to highlight that today is also National Fentanyl Awareness Day, and May 7th is also International Harm Reduction Day. And all of these days have sort of had a confluence together. You know, certainly we want to ensure that harm reduction services, an integrated approach to treating individuals with substance use disorder and reducing infectious disease transmission, they all share equity. And of course, harm reduction refers to policies and programs and practices that are really aimed at reducing the negative impact of substance use. And that'll include overdose risk as well as infectious disease transmission. So as we are partners within HHS, an integrated approach, a whole person approach that these programs that are going to highlight today really do speak to how those policies come into practice. We know that individuals who engage in substance use, particularly injection drug use, are at increased risk of contracting and transmitting viral hepatitis, HIV, and other infectious diseases. And many of those who have hepatitis are unaware that of their diagnosis. So individuals who are entering substance use disorder treatment may not know their status, and discussion with a provider may be the first conversation they actually have. And that provider at intake is required to do screening. And this really is the syndemic approach that HHS has espoused. And many states have modeled great programs. Medical staff members at SUD treatment programs have a primary role for screening for hepatitis, as well as other infectious diseases, and explaining those results, as well as medical staff at health clinics, and a mobile health clinic is one of the programs here we'll highlight, have a role in screening for SUD and providing education as well as harm reduction services. The programs showcased here are great examples in integration in action and the syndemic approach. So again, thank you, Dr. Merman, for your leadership. Thank you to the SAMHSA staff and CDC staff who are presenting. and also to our wonderful grantees featured here. The implementation efforts that will be highlighted here serve as models that hopefully will be replicated across states and jurisdictions. I'll now turn it back over to Kristen Roja.
Thank you very much. And thank you for your opening remarks. So next we will have a series of 3 presentations from our excellent panelists, followed by hopefully we will have time for a moderated discussion and Q&A. So with that, next slide, please, and I will introduce the first presenter. So our first presenter is Dr. Nick Saval. Dr. Saval is a board-certified infectious disease and addiction specialist. He is an assistant professor at Drexel College of Medicine and sees patients at the Partnership Comprehensive Care Practice in Center City, Philadelphia. He is co-PI and director of medicine of the Drexel Hope Mobile Health Unit. His additional interests are in clinical research and in the intersection of infectious disease with addiction. Dr. Saval, I turn it over to you.
Thank you so much, Kristen, for the introduction. And on behalf of Drexel Hope, we'd like to thank the CDC, SAMHSA, and the organizers for featuring our work. Next slide. So Drexel Hope is a SAMHSA-funded mobile health unit that focuses on providing low barrier management of OUD, HIV, and viral hepatitis, specifically to communities of color in Philadelphia, followed by linkage to care. And the historical core of our services has been provision of MOUD, namely buprenorphine products, together with opt-in viral hepatitis and HIV screening. And I'll be sharing with you how this mission has really evolved in the past year. I mentioned some of the core of our services, buprenorphine induction, linkage to longitudinal care, Hep and HIV screening. We also offer PrEP and PEP for HIV, wound care, and other services listed here as needed. We have a multidisciplinary team, so that includes 3 medical providers. We have a clinic social worker on the van who is also behavioral health consultant trained, 2 peer recovery specialists, and a tireless program manager who keeps it all together. We are out on our locations 2 days a week. So currently, on Tuesdays, we're in South Philadelphia, and on Thursdays, we're in West Philadelphia. And we'll typically change our locations every 4 to 6 months in response to data that we'll get from our city health department on overdoses, and more recently on new cases of hepatitis C. Next slide. This is a diagram of the patient flow through our program structure. And it starts with outreach and education. And the core of this is really done by our peer recovery specialists. And this is how patients end up coming into the HOPE program. And one thing I'll say kind of as an overview is this is the structure of our kind of original SAMHSA grant defined HOPE program. And then I'll talk about what our expansion looks like. And that outreach that's done by the peers happens in a variety of ways. So this is street outreach that happens on days that the van isn't out. This is liaising with community partners. This is inpatient substance use programs. This is recovery housing, outpatient programs. And then we have people who walk up as well when the van is out. The next step is program enrollment, and folks are eligible per kind of the original program if they have a diagnosis of opioid use disorder and are not currently on a formulation of MOUD. And this is a variety of different types of folks who meet those criteria. It could be people who are not diagnosed with OUD, could be people who were diagnosed with OUD but had not received treatment. But kind of the majority of what we see is people who have OUD, have probably had some MOUD experience, but have either fallen off of it or not in it currently for a variety of reasons. People do our intake assessments, are offered screening for HIV and Hep C, and then meet with the providers to discuss BUP induction. And per our core services, folks are typically seen for an average of 4 visits. And these are weekly visits, so typically about a month. prior to linking them to long-term care. And some of the wraparound services that we've always had is getting insurance reactivated, screening for other psychosocial or mental health needs, and really trying to address those needs either on the van or in terms of where they end up linking. And folks link to a variety of different programs. So some of that is more addiction oriented IOP programs. We do have people who go directly into inpatient substance use treatment. But the majority of the folks actually end up getting MOUD and typically buprenorphine through primary care providers and other providers who are historically ex-waivered and now providing Suboxone. Next slide. So this core program activities began in late 2020. And as I kind of alluded to, routine HIV and Hep C screening was offered, relatively high declination rate. If people did test positive for Hep C, typically this is through point of care antibody testing. So we weren't able to kind of give confirmatory diagnoses for viremic Hep C. And a lot of that stuff would happen through linkage. If they end up linking to a primary care program, we would try to find one that would be able to address the needs of diagnosis and management for Hep C. And in 2023, we applied for and got 2 smaller grants with the goal of expanding our viral hepatitis services and really the vision of conducting the entire Hep C cascade of care directly from the mobile health unit. And so one of these was through the Philly Department of Health, a Hep C integration grant, and then a small foundation grant through Hep B Foundation, Hep B United, specifically for hepatitis B serostatus and prevention. Next slide. And this is a roadmap of how we did it, and that kind of brings us up to now. And the most important person there is on the top right. So, and that is our nurse navigator, Kim Burkhart. We call her the viral hepatitis eliminator. And she addresses a number of pinch points that existed on the van before. And a big one is phlebotomy. Being able to get labs when people are having their concurrent HOPE visit is something we weren't able to do before. And so that includes, being able to confirm a diagnosis of viremic Hep C or show that someone is cleared. It includes being able to get staging labs for things like fibrosis, other labs that are necessary, and also assessing serostatus for Hep A and Hep B. We got all of the staff trained up. So we did a Viral Hep 101 for all staff to increase program proficiency. Similar trainings for medical providers, really to gain proficiency on the Hep C treatment guidelines. And one addition to this in terms of the testing through phlebotomy was this pretty key expansion of really who we were able to test, including people who were not getting buprenorphine from us or may not have opioid use disorder. And what this has evolved to in the past few months has been walk-ups to the van and increasingly community events that we're doing. And for hepatitis C, this all coalesces on treatment. And what this looks like for folks who are amenable, they may test positive through an antibody test and then get their labs that day. They may have a known history of Hep C or know some part of their history and go directly to lab work. And we offer people, 2 different routes of how they want to get their labs. If they're open with getting a whole suite of labs, and we may not need all of them. If they really think they have Hep C that's viremic, we can do that. In which case, a few days later, we're able to review those labs, speak with the specialty pharmacies that we work closely with, and by the time they come in next week, have the meds ready on the van for dispensation. For a lot of our folks, they're 8-week courses, and people really just want to have 1 week at a time if they have marginal housing or afraid they may not be able to keep their meds safe. And that's one of our most streamlined ways of providing treatment. And we keep people who are getting Hep C treatment on our van longer. So I mentioned people may have been on the van for a month while we link them to care. The goal is in this kind of liminal period, we keep them and shepherd them through. If they're getting buprenorphine, they get that too until we really get them treated and then linked. And then lastly, we continue to be a linkage program and offering wraparound care, which in this case is assessing serostatus for Hep A and Hep B, providing vaccination, and theoretically chronic Hep B care as well. Next slide. Here's some of the demographics of our program. And so this is going to be of the core HOPE cohort. So it doesn't include walk-ups, doesn't include some of our community events. But I will say this is really the majority of the folks that we've seen. And this goes back to our data from 2020 as well. About 2/3 identifying as male, 1/3 female, a little over 50% African-American, about 1/3 white. Next slide. And then data on age and ethnicity. And you can see here the median age from the blue column in the middle, relatively young, ages 35 to 44. Next slide. So here are our numbers. And a word in terms of the date ranges. We ended up getting those 2 small grants in October. Things really started in earnest about 3 to 4 months later. And part of that was because it was, getting the nurse navigator on the van. At some point we had her part-time, and then it was about February where she was on the van for both of the days. It was working through our processes for figuring out how to deal with walk-ups, how to think about what gets processed through insurance, what's point of care, what goes directly to a blood draw, how do we get people registered in Epic, which we do have on the van. And then some of it was just the vagaries of life, that we had a generator issue on the van throughout January. So we did the best we could with telehealth. So it was really in February in earnest when, we had the whole suite of our interventions. For hepatitis A and B, you can see 25 to 26 people tested. And these are all going to be people, of course, who have had blood draws. No acute cases of Hep C identified thus far. About 20% of people antibody negative, a fraction of those receiving their first dose of vaccine. And for Hep B, thus far, no people with chronic Hep B identified yet, antigen positive. Interestingly, 40% of people antibody negative in a relatively high risk, high prevalence population of exposure. And about half of those people have received at least 1 dose of the vaccine. And then coming over to Hep C, I'll show you a cascade of care in the next slide in just a second. But about 1/4 of people either antibody positive or known history. 11 of those people have viremic Hep C. And we have 4 people currently in treatment, 5 people who have actually completed their treatment. And I'll just round it out talking about HIV. We've tested 74 people to diagnosed with HIV. Were immediately started on ART same day and linked to care. I will note pretty low uptake for PrEP here. 2% so far is what we've seen. Next slide.
And this is your 2-minute warning.
Okay, so I'll speed up then. And I talked about a lot of this. I think the first 2 columns, that gap has probably really reduced as we've increased opt-out testing in the past few months. A couple notes in terms of the people treated. Of all the 5 people completed, none of them are up for their SVR yet. A couple of them have had early viral loads checked that have been negative, which is really great to see. So we're really hoping for cure. And of the 9 initiated, 8 are still in our care. 5 of those are the ones who completed. We've had 1 who's lost to care. Next slide. So I'll end by just breaking this up into successes and barriers. I think an obvious success that we're really happy with has been being able to provide Hep services for all. About 90 to 95% of our patients are insurable, but even if they aren't, through provision of the SAMHSA grant, if they're HOPE eligible, we can get people covered for Suboxone, and we're doing a lot with point of care testing. And this is for people who may not have OUD, may use other substances. Co-locating the services has been really key, because I think even if people have hierarchy of needs, they're also getting their Suboxone if they have OUD and they're out of care. We had 1 person who got injectable. So we're really kind of trying to explore making this as accessible for patients as possible in terms of what they need. We've streamlined insurance and pharmacy processes, and we can touch on this in terms of, point of care Hep C viral load testing, and we do have great specialty pharmacies we can work with to adjust processes to even do same-day initiation. We'd have to work through some kinks, but I think it's possible. And I'm proud of how we've been able to navigate transition of care, working with Department of Prisons, working with inpatients, making sure our folks, if they end up in these different institutions, they can still contact Kim and we can still make sure people know what's going on with them. Next slide. And I'll be quick here. Things got a little skewed. You know, an ongoing barrier, what we're seeing is this major theme of level of psychosocial comorbidity, stigma, and competing needs that our patients face. And that affects housing, phone access, venous access even, stigma approaching our program. The last two things I'll say is two barriers we're actually getting assistance with through our Department of Health. And the big one is funding. And I think a lot of programs like ours would like to learn more about what it would look like to get 340B funding or how to navigate getting continuity funding in municipal budgets. And if public health and policy makers like the work that we're all doing here, I'd love to get support in making our programs permanent. And we're still figuring out vaccination. You know, we had some vaccine partners. They weren't really getting the volume they were looking for. Right now, we're parked right next to a Walgreens, which helped. So these are some of our opportunities for growth. And next slide, that's my last one, and I will end there.
Thank you so much for that excellent presentation, Dr. Saval. Next, I will introduce, let's go to the next slide. So our next presentation, I will introduce our co-presenters, Dr. Seth Himmelhoek and Wendy Potts. Dr. Himmelhoek is the professor and chairperson for the Department of Psychiatry at the University of Kentucky College of Medicine. His research focuses on developing and studying the efficacy of innovative strategies aimed at improving the health and welfare among people with co-occurring psychiatric and substance use disorders. And Wendy Potts serves as the program director for the Division of Services Research in the Department of Psychiatry at the University of Maryland, Baltimore. In this role, Ms. Potts manages the day-to-day operations of all research and staff. With an eye to the full research portfolio, she brings a programmatic vision to informing high-quality research activities through efficient, effective, and impactful processes. I will turn it over to both of you.
Great. Well, Kristen, thank you for the warm introduction. And thank you to our federal partners for allowing us to present today. Today, myself and Wendy will be presenting on two programs, both of which implemented the STIR intervention, which I'll describe in a moment, among individuals who are at high risk for hepatitis C and HIV, those being people with co-occurring substance use disorders and psychiatric disorders. And we're going to share the results of two SAMHSA-funded programs that we've implemented this intervention. Please go to the next slide. So what does STIRT mean? STIRT is an acronym, and it stands for the S for screening, the T for testing HIV and hepatitis C, I for for immunization for hepatitis A and B using Twinrix, and then the two R's is for risk reduction counseling. The IT stands for integrated treatment, with the goal being that we provide all these services in a co-located and integrated way within either a behavioral health or a substance use treatment setting. The original model that was simply called STIR was created by Stan Rosenberg back in the early 2000s. It was based on CDC guidelines and tailored specifically for the needs of people with co-occurring substance use and psychiatric disorders. That tailoring was iterative and systematic and led to the final product, which was the STIR intervention. That intervention was provided by a trained nurse and delivered over 4 sessions. 3 of the sessions were in line with the Twinrix vaccination, and I'll share with you what those 4 sessions were. In session 1, a participant would receive screening and testing for HIV and hepatitis C and begin their risk reduction counseling. Based on their results of their testing at session 2, they would then either be referred either in-house or to another location to receive HIV treatment, and then over time, when the hepatitis C treatment became available, to receive hepatitis C treatment. They would then, with their consent, receive their first Twinrix vaccine, and then continue to receive risk reduction counseling. In session 3, which was 1 month later, they would receive their second Twinrix vaccination, continue to receive risk reduction counseling, and then finally, at 6 months from their baseline, they would receive their final Twinrix vaccine and a summary of the risk reduction counseling, and with the opportunity to get more assistance if needed. During that whole time, there was a team of the nurse would help be a care coordinator for both HIV and hepatitis C treatment. Please go to the next slide. The model itself was meant to be highly adaptable and, as I said, co-located and integrated within the treatment setting. The goal was to have the nurse be part of the staff, so integrated within the treatment facility. The nurse would have an accessible office to work from. There would be on-site blood drawing facilities and a safe place to store vaccines so that they could be delivered on site. As the treatment, as the medical records evolved, we also then added on the connection to the electronic medical record in order to enable both all of the parties, being the participant, the clinician, and the nurse, right? Everyone working together to have all the information to ensure that the participant did not fall through the cracks and did receive all the appropriate treatment to reduce their risk and to provide them with immunity for bloodborne infectious diseases. Next slide. So I'll begin with talking about Project 1, which we called STIR-IT. This was an intervention that was located at a behavioral health treatment facility in Baltimore, Maryland. What you're looking at is the pamphlet that we would work with the participant to understand what their risk reduction or what their risk was, and then strategies that they could implement to provide themselves with risk reduction. This was a person-centered intervention, again, provided by a trained nurse. If you go on to the next slide. Over the course of the 5 years that we had this grant, we were able to reach 270 participants. Of those 270 participants, the vast majority self-identified as African American. The average age was 53 years old, and at that time, that was right in the cohort of people who are at highest risk for hepatitis C. So that was a helpful alignment in our strategy. In terms of gender, 50% were female. As you can see, the vast majority had a diagnosis of serious mental illness. And what I mean by that is they either had schizophrenia, bipolar disorder, or depression that was recurrent. And among that group of people, the vast majority had a history of substance use disorder, including some injection drug use disorder, using injection drugs. Can you go to the next slide, please? So what were our outcomes? The first most important outcome was that we were able to successfully set up the model and implement it and maintain it throughout the course of the 5 years. I'm happy to report that nearly all the clients who agreed to participate participated in all 4 sessions of STIR-IT. And in terms of our outcomes, we were able to determine that 15% of the participants who were willing to get screened were HCV positive, 8% were HIV positive, and we're able to refer 100% of them to care. I do want to note that among those who are HIV positive, all of them knew that they were HIV positive. That's in contrast to the people who are hepatitis C positive, many of whom did not know they were hepatitis C positive, and this was their entry into getting treatment and care for that. If you move on to the next slide. The next slide just shares 2 papers that we published on this data, particularly describing the continuum of care for hepatitis C. So among the people who were found to be hepatitis C positive, although 100% were referred to treatment, only 75% accepted being, actually going into treatment. Of those that accepted being in treatment, about half of them completed treatment. So that's, I think, very good in terms of thinking about this particular population. I also want to say that of those who we offered immunization to, 68% accepted immunization. So there was a significant, I don't know if it's significant, but there was a substantial minority of people who declined to have it. And the reason that we were able to find with talking to them was just the idea of being avoidant of having to be vaccinated, which, given our history and knowledge of COVID, this is kind of known within the community. So I'm now going to transition and hand off the next program that we implemented to my colleague Wendy Potts, who will share the outcomes of the Athena program. Next slide, please.
Thank you, Seth. So after completing our SAMHSA project at the mental health clinic, we were able to receive another SAMHSA grant. And we took this project to a methadone clinic about 5 or 6 blocks west of our first clinic location. And we ended up calling this project Athena. And what we were doing is our target population was minority women who attended the clinic. And as you can see, we updated our brochure when that we would look at with the women when we would meet with them for their sessions. So as you can see, we went over looking at hepatitis A, B, and C, as well as HIV. This form could be filled out as we met with them, so they could take notes and we could write things down to make sure that questions were answered, and we had making sure that everything was taken care of during their 4 sessions, and if not, we kept meeting with them. Next slide, please. So far to date, we are wrapping this project up at the end of this fiscal year. We have had 184 women come into the program. 79% of them identified as African American. And a little bit different, they were slightly younger at this clinic with our average age of 54 years. So far, similar to Seth, 65% were diagnosed with a diagnosis of mental illness, and everyone there had a history of substance use disorder. As most folks will know who have current projects with SAMHSA, in the middle of this project, COVID came. So we were definitely hoping for some more numbers, but I feel like for the project reaching 184 participants during the time of COVID and throughout the project was still very successful. Next slide.
And this is your 1-minute warning.
Sure. So far, we have successfully implemented our model that Seth talked about, 184 participants. And this was as of last week. And 65% have completed all 4 of the STIRRT sessions. And like I said, I think some of the, only 65% was mostly attributed to folks that we lost during COVID, either to moving out of the area to end up with other family members who took care of them, or just they had to relocate with housing and they left the clinic. We maintained a 14% hepatitis C rate, and for majority of clients, like Seth had mentioned, it was new to them. 6%, a little over 6% HIV positive rate. Although folks all knew they were HIV positive, we had a social worker in our program who was able to interact with every patient who was in the Athena project and refer them to care, not only for hepatitis, HIV, housing, pretty much any need that they came in. We had a dedicated full-time social worker, which was really helpful in this case, because a lot of our folks at the methadone center struggled with many issues and concerns that having Allison as part of our team, was really able to sit with them, take time with them. Some folks met with her weekly for months at a time to get even the smallest of things that were helpful, a license, vaccinations, things to that nature. So everything that was done at the clinic. Our clinic was 2 floors and everything was done on site. So blood draws and everything were done by medical professionals that folks were already familiar with, had rapport with, and that they saw on a day-to-day basis. Next slide. So that's from us. Thank you. And we will answer questions later.
Thank you so much. Now we'll turn to our third presentation of the day, which is going to be presented by Dr. Christine Teague. Dr. Teague is a clinical pharmacist, specialist, and director of the Charleston Area Medical Center's Ryan White Part C Early HIV Intervention Services Program, which provides HIV testing and linkage, as well as care and support services to over 500 individuals living with HIV who reside in southern West Virginia. Dr. Teague holds adjunct clinical pharmacy faculty positions with both West Virginia University School of Pharmacy and University of Charleston School of Pharmacy. Dr. Teague, the floor is yours.
Thank you, Kristen. And I would also like to extend my thanks to the folks from CDC and SAMHSA for the opportunity to speak with you all today and to talk about our experience with integrating services for people who are under-resourced in our area. Next slide. So our program has been a Ryan White Part C grantee since 2000. So we're on year 22, 23 of being a Part C grantee. We serve Southern West Virginia, so 19 counties in the coal fields, essentially. And we've also been able to access some additional funding through Ryan White Part B and some additional private foundations since the program began. Next slide. We're housed in our main clinic building, which is in the outpatient care center of the CMC Memorial Hospital. We have 4 sister hospitals amongst the CMC system, which is a part of the larger Vandalia Health Network, which is statewide now. We expanded to Beckley, West Virginia, which is about an hour south of Charleston, about 5 years ago. And we have a clinic there, which operates 1 day a week. Next slide. And as a typical Ryan White entity, we provide the whole gamut of comprehensive medical services ranging from linkage and testing within the hospital for high-risk individuals, as well as in the community, and treatment, of course, for HIV, Hep C, addiction services, gynecology and pregnancy care, specialty referrals for those individuals that are HIV positive. Next slide. And as a wraparound program, we were able to provide those necessary support services to keep people engaged and retained in care, such as transportation. We have a food pantry. We provide contingency management through gift card incentives to our patients, and some emergency utility and housing assistance. Next slide. And we knew from probably early on in the early 2000s that Southern West Virginia really was on track to be sort of the setting of an outbreak or a cluster of HIV. And that has happened in West Virginia. There are 2 ongoing larger outbreaks, one in my county of Kanawha, and there's some smaller clusters that have popped up as well. Starting in January of 2019 to currently, there have been 134 known cases compared to previously we would see less than 5 people. 13% of those people have died. 90% have had some care with our program, and 50% are consistently on medications and undetectable. Obviously, this is related to injecting drug use, and this outbreak, that's what's part of the case definition. Many are experiencing homelessness, and I would say 70% of the group in Kanawha County are located on the west side of Charleston, and the others are kind of in the other remote areas of eastern Kanawha County. These individuals are between 20 and 40, half female, half male. Most have hepatitis C co-infection, and half were diagnosed in the hospital, very, very sick with other complicating infections. Next slide. So we knew very early on that our traditional model of care, providing services to people in the clinic on one side of Charleston, away from the other side of Charleston where people were residing, people were just not able to come to a clinic for a variety of reasons. So we knew early on that we had to go to where they were. And so we identified a mobile, we had a van at the time that we were taking out, and then we were able to secure actually a fully equipped mobile medical unit 2 years into that. So we knew that we needed to go where the patients were or go, and so that was the west side of Charleston. We had to identify partners that were willing to allow us parking. And so we identified a space on, it's actually on one of the main drags across from a restaurant and a Family Dollar store that allowed us to park there. And we knew that we wanted to integrate and provide the full array of medical care for not only HIV, but for other STDs, hepatitis C, and addiction care. We had to research state regulations regarding if we needed special licensures or any type of certificate of need for that, and as well as figuring out what other type of resources that were going to be required, such as tables or tents on the outside of the mobile unit. And then finally, we had to really think hard about marketing. One of the huge barriers to care in this area is stigma. Not only HIV stigma, but SUD stigma and homelessness stigma altogether. So we had to sort of rebrand ourselves as just Charleston Area Medical Center and not necessarily a Ryan White program. And we had to get creative with how we were going to have marketing about this to preserve confidentiality. Next slide. And so other key parts were having hospital leadership buy-in to support thinking outside the box for, we've always been a, in-hospital clinic-based delivery system, and they were willing to say, hey, okay, you can try this. We had to have adequate startup funds, and fortunately we had federal, state, and private foundation grants. We worked very closely with our IT and pharmacy departments to allow for access to the electronic health record, which is Cerner for us, and having that availability actually on the unit so that we could register patients and make notes into the patient's chart, and then having a referral base for other specialty and addiction care services, as well as buy-in from the community to let us park there. Next slide. So again, we started out, the outbreak started in really full force in 2020. We acquired our cargo van in 21, 22, and that's what we were taking out into the community to do point of care testing. We were giving people hygiene bags and food and Narcan and harm reduction counseling, bleach kits. But we really didn't have the array of medical providers at that point, but we were talking into establishing relationships with patients. Next slide. And then in 2023, when our full medical unit was delivered, we were able to integrate all of that. So we have a full year of data. We provide basic medical care, wound assessments, 7-day dispensing of HIV, Hep C medications, mental health medications. We provide hepatitis A and B vaccines, antibiotics for STD. We have a phlebotomist on site. And more recently, we have integrated women's medicine so that they're there once a month providing access to birth control and long-acting contraceptives. And this year we plan to integrate MOUD, bridge therapy prescriptions, and linkage to MAT centers for longitudinal services. We're also planning to bring on a primary care provider outside of Ryan White so that we can do just basic primary care and pre-exposure prophylaxis, given some of our funding limitations with Ryan White funding. Next slide. It's a beautiful unit. The unit that we're using has 2 full exam rooms, an area for phlebotomy and intake. Next slide. And then a second unit that we're getting this year is a little bit smaller, so it will be a companion to the larger unit that has 1 exam room. But we, again, you can see our messaging. We don't say anything about Ryan White or HIV or SUD. It just says compassionate care, with a depiction of what looks like a very diverse group of individuals. Next slide. We're very proud of our outcomes. In that year period, we've seen at least 50 patients. About 40% of the outbreak have been seen at least once on that bus. Actually, now it's probably closer to 60 people. We average 25 to 30 patients that are coming per week, over 1,000 encounters in 2023. We did almost 600 point of care HIV and or syphilis tests. I think there were 4 HIV positives last year. Of course, they were all immediately linked to care. 16 people were treated for syphilis. We did 318 point of care hepatitis C tests. Many of the folks knew they already had hepatitis C, or they didn't want to hang around for the 20 minutes to get their result back. But of that group, about a third were reactive. And this year, as we get primary care on board, we will be able to do just get them immediately onto the bus to do a viral load, and then hopefully same day treatment. The thing that I'm most impressed by is that since this initiative began, the total number of new infections related to injecting drug use reduced by 76% from a peak in 2021 to 2023. So I think that treatment as prevention really is working, because of state regulations sort of making syringe programs almost impossible to obtain and do effectively. And with low uptake of PrEP, I really do think that this treatment as prevention is what is driving the numbers down. Next slide. Of that active group being seen on the mobile unit, 80% have undetectable HIV viral loads, 50% have reduced their hospital utilization, 2/3 have received either inpatient detox or have engaged in outpatient MAT services at least once. 50% are engaging in harm reduction counseling weekly, and of that group, nearly 75% have made positive change in their substance use practice, i.e. going from injection to smoking. 83% of the people that are clinically indicated or are viremic with Hep C have currently received or are ready to receive treatment. So 5 have completed, 3 are receiving, and 9 are in the process of receiving. And 74% of this group now is actively sheltered. And for many of them, that's been the first time for them in 5 years. Next slide.
And this is the 2-minute warning. Thank you.
Great. It obviously that doesn't go without challenges for us. IT support and connectivity. We have had some Wi-Fi issues and actually getting access to Cerner, but we're working on that. With all the stuff that's on a mobile unit, with all the maintenance that is ongoing, it's not always available every week when we go. Again, being a primarily Ryan White funded program, either through the grants or through Ryan White revenue, we have to be able to figure out how we're going to get other funding streams to cover services for patients who are not necessarily Ryan White program enrolled. Just the drop-in nature of care, we don't schedule appointments. People come when they can. So that always poses a set of challenges. I think, as mentioned in the first presentation, these are hard sticks often. Patients are often dehydrated, they have bad veins, and so we may not get, when they're ready, even when they're ready, they may not be able to get all the blood that's necessary. In West Virginia, injectable Cabenuva is not on the Medicaid formulary. It does require a prior authorization. So there's more hoops to jump through to get long acting, and there's, I think, several people that would be good candidates for that. For some patients, actually getting transportation to the mobile unit can be challenging. We're working with Uber Health to work through some of that. And again, being creative with community messaging. Next slide. I think the biggest win is just gaining the trust of our patients. We knew that going into this, that some of the patients' hospital experience with CMC wasn't the greatest. And so being associated with the hospital system, we had to gain that trust and, be kind and respectful and preserve their dignity. We've developed many, many wonderful community partnerships, and we've been able to leverage multiple sources of funding and have had really, I think, really great hospital administrative support. Next slide. Lessons learned, change doesn't happen overnight. This took 4 years to have good outcomes, but it's happening now, and we're still working, we're still developing. We have a lot more that we want to do. It's important to educate not only the population that you're serving, but the community and law enforcement. Stigma and lack of housing options are still our biggest barrier. And I think the biggest thing we've learned is that you have to bring services to patients rather than the other way around. And using peer recovery support specialists and community health workers in the community to sort of forge and develop those relationships are vital in paving the way for acceptance. Our experience shows that incentives, contingency management, and kindness works, and you must have collaboration between agencies. Next slide. Just a couple of photos. We actually work with the Street Dog Collective, and we have some days where we have vets on site that we treat both ends of the leash, so to speak, and I just love that, being an animal lover. Next slide. And this is a group of our folks on the unit. So with that, I'll close and also take questions with the rest of the group.
Thank you so much for the excellent presentation. Now I would like to turn it over to my co-moderator, Dr. Nate Furukawa, we may have time for a question or two.
Yeah, let's try and squeeze a quick question in here too. I think the first question, and just I'd like to pose in seeing all these wonderful presentations and really truly successful models of care, is that, you know, on our side, we're really hoping to move the Hep C field towards increasing simplification and decentralization. I think you guys are on the forefront of that for sure. And on our end, we're working to bring a CLIA-waived point-of-care fingerstick Hep C RNA test to market, as well as working with the specialist societies to bring about further simplified guidelines that could facilitate same-day test and treat algorithms. So I guess a quick question is, how easy do you think this could be incorporated into your respective programs? And then would you foresee any potential challenges that remain?
I can speak to some of that. And I think it would be really cool to have, because you can make that viremic diagnosis without getting a blood draw theoretically, which, you know, as the Charleston group was presenting, Christine, sometimes just getting blood is really tough. I think if it were paired with some guidelines for how programs should use it, that would be good, because I think we all kind of think about what it means to assess for fibrosis and what it means to assess for chronic Hep B. And yet a number of our folks are, you know, less than 35. And, you know, we haven't seen any chronic Hep B in the cohort I presented. So I think those are all things that are surmountable. The pharmacies, the specialty pharmacies are ready. So I'd be very excited to see how that goes.
And I'll just add, you know, from our standpoint in West Virginia, you know, virtually all of these folks that we're talking about, at least that we would be seeing on the mobile unit, have Medicaid, West Virginia Medicaid. And right now, all of the Hep C medicines do require prior authorization. And as part of that, you have to have in-hand labs to present as part of your prior authorization package, such as the fibrosis score and the viral load and a pregnancy test and all of these things that, as Dr. Nick alluded to, you know, if we could make the case that we can get these things, but not necessarily, I don't think we necessarily need to have them on day one. But right now, I think that's going to be a hoop that we would have to jump through to, at least just for access, and maybe have a starter pack, 7-day starter pack of meds, so that you could start the meds and get them approved through West Virginia Medicaid, and then have that, you know, next 7 days ready for them when they come back the next week. That's the way I would see it potentially happening.
Yeah, excellent. And then very quickly, we have a question from Michael about commenting on why the PrEP uptake seemed to be relatively low in this population.
I'll address that too while I've got the mic on. Our experience is that when you talk about hierarchy of needs in the particular population, many of them are living day by day, and it's, you know, shelter and food and just basic survival. And so I feel like just getting them to the point where they will take the oral medications for the actual treatment of things has been a major win. And so getting them, to understand the adding another medicine when they don't really understand that this is something that could prevent them from acquiring the infection in the first place. It's been low. West Virginia Medicaid does cover Apretude in West Virginia, but it does require labs, and sometimes patients, the ones that are not necessarily our patients enrolled in the Ryan White program that we see every week, getting them to come back on a regular basis to get their infections might also be challenging. But I think a lot of it is just increasing patient awareness and getting them to buy into doing that every day. But it's tough when you're, literally just trying to survive day to day with all the issues that are going on for them at the moment.
Thank you for that comment. I believe we're now 1 minute over time, so unfortunately I'll have to conclude this webinar. Thanks to all the panelists and the audience for coming together on this really critically important issue. We really appreciate everything you do. We will be posting this recorded session online in about 2 to 3 weeks, and we look forward to seeing how your programs evolve, and wish you the best of luck.
Thank you.
Thank you
Thanks
all.
so much.
So.